Hi, welcome to Walsh Urology. I am Dr. Lance Walsh. I'm a urologist, board certified. I've been in Coachella Valley since 2007. We have a state-of-the-art office here in the Valley where we can perform a wide array of procedures in the office. This includes the new UroLift technique for treatment of benign prostatic hypertrophy. The success of the UroLift procedure starts at the front door. When the patient enters the office should be calm and inviting. When they meet with the receptionist, they should be greeted with a smile and know the reason why they're here.
Mr. Lewis?
They should be brought back to the room in a timely manner. This does require coordination from all members of the staff. And the coordination is key to the patient's experience. The patient will rate the experience, not only of the procedure itself, but the entire experience in the office.
Good morning.
How are you?
Good.
After the patient checks into reception, they're brought back and taken to the restroom to provide a urine specimen. The specimen is then processed with a dipstick in order to ensure that they do not have a urinary tract infection. They're then brought back to the ultrasound room where they're placed in the lateral decubitus position, and a prostate ultrasound is performed, as well as local block, periprostatic nerve block with 1% lidocaine. For their comfort, the room lights are dimmed, and also music is playing.
And to administer the medication, okay, he's going to be using a lidocaine
And they're informed of each step of the process throughout the entire procedure. After the local anesthetic is applied, they're brought to the cystoscopy room. Approximately 20 to 30 minutes have elapsed, allowing the local anesthetic to take full effect. They're brought in and laid supine on the table and then placed in the modified lithotomy position. The video tower and cystoscope equipment, as well as retrieval kit, have been placed, and a blue drape is placed above the patient's torso to block his view of the procedure. Once the procedure commences, we have a staff member engage him in conversation as to distract him from the procedure. This so-called verbal anesthetic plays a very important role in the success of the procedure, making them more comfortable. So here's some technical pearls. When inserting the cystoscope through the urethra into the bladder, you may want to ask the patient to try to void. This will help to relax his external sphincter, making the rigid cystoscope easier to place through the urethra. Obviously, when you're going through the prostatic urethra, you want to take note, again, of potential placement of the implants, and be very careful when going over the bladder neck, as that is a very sensitive area. Upon entering the bladder, remove the visual obturator and then exchange for the UroLift device. This is rotated 90 degrees, so it can be applied laterally in the prostatic urethra. Again, it's important to avoid being too close to the bladder neck, and to avoid placing the implant into the bladder itself that would require removal. There are various techniques to improve the anterior channel. This can include stacking if there's a need for that. In addition, it's important to assess the results with the bladder empty, just to make sure that there is a true anterior channel through the urethra, and if there's too much water pressure, that may hold the prostatic urethra open. Finally, it's important to have slow and deliberate movements when doing this, and when you're applying the implant, let the patient know that they may hear a loud snap, and so they're not startled by it. So I'd like to say a few words about discharge and follow-up. We monitor the patient closely during the procedure with continuous monitoring of vital signs. This occurs, again, after the procedure, and this is documented before they go home. They're typically given follow-up appointments at 2 weeks, 3 months, and 1 year. At each of those appointments, we have them fill out the IPSS questionnaire and then also obtain their feelings about how the procedure went. A very strong selling point of the UroLift is that it has absolutely no effects on sexual function. There is no increased risk of erectile dysfunction or retrograde ejaculation. So who is the ideal candidate for the UroLift? It's one for patients that are on medical management that either are having side effects like dizziness, asthenia, or it's just not very effective. Or for patients considering having a transurethral resection of the prostate but don't want to have the side effects or long recovery period that's required, especially patients that are active. And this also includes patients that are poor surgical candidates but may qualify for the UroLift. It offers rapid, significant reduction in the AUA symptom score with reduction in the quality of life score that is almost equivalent to a transurethral resection of the prostate. It's important that you discuss this UroLift option with them when talking about BPH, and even when starting them on medication, and using the round handout that compares each of the treatment options.